So welcome. My name is Professor Saku Mantere. Well, the professor isn't a part of the name, but we like to stress that. I'm director of the Marcel Desautels Institute of Integrated Management, which is the organizer of this fine event. Tonight we're going to be talking about healthcare and healthcare organizing. And I'm particularly delighted that we're able to do this event because, as an organizational theorist myself, I think, healthcare organizations are among the most inspiring organizations in terms of how they're managed, because the human implications are so broad and so self-evident. And I'm particularly happy that we're talking about sort of patient or client-centered, human-centered healthcare systems. Because we all, I think, especially once we get a bit older, we may have experiences ourselves of being bounced around healthcare systems and sort of how frustrating and destructive it is to be kind of dealing with this bureaucracy, not to mention that we have a loved one who gets passed around in these systems. And when we do that well, it's particularly inspiring. So that's what we're discussing tonight. And the title of the talk is Redefining Healthcare, Transforming Healthcare Systems for the 21st Century. And it's a symposium event. I will be introducing the speakers in just a minute. I do want to mention, and you may have seen some slides, rotating in the background. There's a common theme to this event, a very broad theme: sustainability. So we're committed to addressing grand challenges, just beyond these discussions. So these events are organized in a manner that is compliant to principles expressed by the McGill's Office of Sustainability. Well, our guests. So we are thrilled to be welcoming one of our esteemed alumni. So Susan DeVore used to study in this very room in the International Health Leadership program, graduating in 2010. However, that isn't her only sort of, merit in this life. So she's done some stuff, before and after. And she talks to us as primarily, not just as an alumni, but as a president and CEO of Premier Incorporated. So for nearly 3 decades, Susan has witnessed the evolution of healthcare systems and has engaged stakeholders to co-develop solutions that support high-quality, efficient, and sustainable healthcare delivery models. So there may be some of you in the audience who are not yet familiar with Premier. We're going to hear more about it tonight. But they're a leading US-based healthcare improvement company uniting an alliance of approximately 4,000 US hospitals and health systems and 165,000 other providers and organizations. So in addition to saving their members billions of dollars and saving thousands of lives, Premier is also recognized as a leading corporate citizen. They have been named one of the world's most ethical companies 11 years in a row. So that's pretty impressive. I hope we will hear what the world's most ethical company trademark, because there's a little trademark here. What does that actually mean to get that? And we are as excited to be welcoming one of our sort of rising star professors, Beste Kucukyazici. I did pretty well. I actually rehearsed that. Kucukyazici. Would you like to try that? Anybody? She's called Professor K by her students because they're wimps, but sort of, So Beste is in operations management, and I'm also particularly thrilled to be welcoming one of our operations management colleagues as a discussant in the symposium, because this is the first time. It's an area of management, and I'm just sucking up to Mori, who's in the field, and he's my boss. But sort of I report to him as the director of the institute. But sort of it's probably one of the most inspiring aspects of management, because we really look at the engineering side of an organizing and how you can optimize processes and organizations to deliver in this case, for instance, human-centered care. So it's I'm thrilled to welcome Beste as well. She is director of McGill's MD MBA program, research associate at St. Mary's Research Center, and research affiliate at the MIT Center of Transportation and Logistics. Her research investigates decision-making problems under uncertainty with special interest in healthcare policy design, healthcare operations, optimization of medical interventions, and medical decision-making. So a worthy discussant for Susan. So thank you, Beste, for also agreeing to do this. Also, I want to flag the contribution of Tiffany Phelps for sort of helping to negotiate this visit, as well as Omer and Megan and our ever reliable tech guys for also helping out. So without further ado, and there was quite a bit already, please join me in welcoming two of our most esteemed speakers.
First of all, I would like to thank you for this nice production and excellent pronunciation of my last name. To Saku, my last name is as complicated as the healthcare system. So. And I would like to thank you for your time and joining us today, and for this great opportunity to discuss about the redefining of healthcare. And I would like to thank all of you for being with us tonight. I believe that, and hopefully you all agree with me, actually, the healthcare system is not only the organization of the institutions or the resources for delivering the care. And the healthcare system for each country, for all countries, healthcare system reflects to their history, to their politics, economics, and the values. So they all vary to a certain degree, but in the meantime, they share principal models and common models and common principles. And unfortunately, one of the commonalities they have is the serious problems they are facing in two important aspects, two important issues in delivering the legitimate needs of healthcare to their patients and being affordable. I just want to give an example in the context of the Canadian healthcare system. You may already know that actually healthcare expenditures accounts for roughly 11% of the overall GDP of Canada. And the growth rate is much faster than the growth rate of the GDP. The annual cost of healthcare system to Canadian economy is around $240 billion a year. And if we only focus for the Quebec context, last year Quebec government spent more than 40% of its budget to healthcare. But however, we don't receive the value we deserve considering all these expense and spendings on the healthcare. According to the recent analysis of the Commonwealth funds, if we look at the performance of the Canadian healthcare system compared to the other OECD countries, we see that the Canadian healthcare system has some problems regarding the accessibility, and it's not surprising for us. We have very long waiting times in the emergency departments, most probably the longest among the OECD countries. We have very long waiting time for the elective surgeries, and we have such a difficult time for finding or accessing to our family physicians. But the interesting part that we are not alone there. Most of the OECD countries are sharing the similar problems. For most of the OECD countries, the healthcare expenditures account for a significant portion of their GDP, ranging between 9.5% to 16%. And in terms of the value of care they provide to their patients, it's not satisfactory as well. So, before diving into the details of our discussion related to the transformation of the healthcare or the redefining of the healthcare, first of all, I would like to get your opinion about the challenge that we are facing. Apparently, we are spending a lot to the healthcare system. We are investing a lot to the healthcare system. But why are we struggling in producing the value out of it?
So first, bonsoir. That's my only French word. And I apologize, so hope you'll bear with my Southern North Carolina, United States accent. Second, before we get into healthcare, because it's such a big challenge, I just want to thank you for my education at McGill. So I didn't go to McGill until I was 50 years old, and I was in the running for the CEO job at Premier. And I credit my getting the CEO job to my experience at McGill. I really do. I came and I was the only American. And so once I adjusted to what all the other countries of the world feel and think about the American healthcare system, and I opened my brain to alternative models, patient-centered care, social models, social care connected to medical care. I actually spent the 2 years that I was in the IMHL program writing the strategy for Premier as a part of each of my assignments at the end of each of the 5 sessions. So for those of you who are students, I would say optimize it, learn everything you can. It will be good for you and for your careers. And for those of you who teach in the program, I would just say thank you for everything I learned in this program. Now to the challenges of healthcare. I think the biggest challenge that most healthcare systems have is they have evolved as extremely complex and complicated systems. I think if we could all blow it up and start over, today we would design a very different system. But because we have incrementalized it over the years, we've designed a system that's very hard to change. In the US, and I'll speak primarily for the US system because I know it the best, I think for us, it functions a little bit like a restaurant. Everybody that comes into the restaurant has to be served, whether they can pay or not. Everybody gets served by servers who don't know what things on the menu cost. The people preparing the food have unlimited ability to choose ingredients. And it's a system that really, if the customer isn't happy when they leave in the US, they can sue the restaurant. And so you have this industry where there's a disconnect between the service being provided, who's paying the cost, and who has control over any of the pieces or parts of the system. Lots of different groups and people have decision-making ability about all the pieces and parts. It's kind of a common misconception that the US is a completely privatized system. It's actually a hybrid model. It's roughly half and half, Medicare and Medicaid, which is our universal programs for people over 65 and for the poor populations, are about half of the spend. It is a $3 trillion budget in the US. We are distinguished by having probably the highest percentage of GDP in healthcare costs. It's an interesting statistic, though, because I think in the US we have very much a medicalization of social issues. And so if you were to take the social care spend and the medical spend and put them together, the US would be somewhere in the middle of the pack. But we spend a lot more money on the medical care piece and a lot less money on the social care piece. And so a lot of the challenges, I think, have to do with the complexity of the system and the misalignment of the incentives and the accountabilities for various parts of the system.
Talking about the changing of the healthcare system or healthcare reforms is not a new thing. But this time, actually, we are just taking it a step further, and we are discussing about redefining the healthcare system. So why do we need to redefine the healthcare system for the current and future generations?
Because it doesn't work. I mean, it doesn't work. My mother died of sepsis that was preventable. My grandson ended up in a hospital with a hip infection that we believe was from a vaccine. And it just doesn't work. There are too many handoffs. There are too much overuse, too much misuse, too much underuse. And so I think the reason we have to redefine it is because it doesn't work, and because it costs too much, and because it doesn't satisfy patients, and because it actually doesn't yield an increase in longevity, and it doesn't yield enough improvement in quality and safety in the healthcare delivery system. And so I think, Premier, we didn't talk a lot about what Premier is. I've been with Premier for 15 years. Premier was an organization that was actually started by healthcare systems, not-for-profit healthcare systems in the US. They were much like, I think, the Canadian system, and still are, with your 10 provinces and your 3 territories, and everybody has autonomy to sort of deliver healthcare in some ways the way that they want to. And therefore, there was no aggregation power because it was all fragmented into the pieces and parts. So the thousands of hospitals got together and they said, well, we'll form our own national aggregation entity. So the 4,000 hospitals that are a part of Premier today basically owned 100% of the company. And the company was designed to aggregate all of their supply chain spending, meaning their drugs, their capital equipment, their medical devices, their commodities, everything, and help them negotiate better pricing to drive savings. At the same time, they decided to start building analytic databases around clinical care, outcomes, cost, resource utilization. And so now here we are 25 years later from the initial formation, and we have data on 45% of the patients in the country, and we aggregate $60 billion of spend to help them negotiate better pricing. And that gives us a lot of visibility into what's working and what's not working. And so as we think about redefining the healthcare system, in the IMHL program, we learned about wicked questions. And the wicked question, I think, for redefining the healthcare system is, how do you simultaneously, not sequentially, not one piece and not the other piece, how do you simultaneously follow the evidence, and the evidence is changing at lightning speed, prevent mortality, prevent harm, improve quality, reduce readmissions, reduce cost, and satisfy the patient? And how do you do all 6 or 7 of those things at the same time? And so we have spent years and years working with the healthcare systems because we don't believe you can wait for the government or the insurance companies to fix it. We have a fundamental belief that the healthcare system can only be fixed from the inside, where the patients reside and where the providers, all kinds of providers, are delivering care. You have to have payment models that incent the right behaviors, but the actual changing the way care is delivered has to sort of happen inside the system.
So once you were listing the performance criteria that you are checking, you talk about the mortality, reduction of the admission rates, increasing the safety and patient satisfaction, which are kind of new concepts to the healthcare. So can we say that in the redefinition of the healthcare, it will be patient-centered?
I think it's absolutely patient-centered, but I think that when we are in hybrid systems that are partially public, partially private, or in purely public systems, it's too easy not to have the patient in the center.
Yes, exactly.
And the bureaucracy is in the center, or the territory is in the center, or the individual role you play is in the center, and everybody's protecting their turf. And so I think where the US has decided they need to go, mostly because of a cost problem, is new models of payment, which actually give a whole bucket of money to a system and say, you figure out how to deliver healthcare more effectively and use the data and analytics that you have to deliver that healthcare more effectively. And so there's a huge push. It's really interesting. I know all of you love President Trump. How many of you love President Trump? Oh, one. We got one who would admit it. So when I was here in school, everybody was excited because Obama looked like he was going to win the election in the US. And when he won the election, he very intently implemented Obamacare, which essentially tried to at least provide access to health care for lots of people that were uninsured in the US prior to that time. And largely we have accomplished that. So then President Trump takes over, tries to repeal and replace Obamacare, can't get it done legislatively, and nobody, and this is on YouTube, I probably shouldn't say this, nobody would admit this, but Obama solved the access problem, and now the Trump administration thinks they need to solve the cost problem. And the Trump administration, in many ways, is thankful that the Obamacare set up an innovation center, funded it with $10 billion, funded the expansion of Medicaid, which is the program for the poor, and in that legislation gave the power to the regulator, not the legislators, to innovate in the Innovation Center new payment models and new delivery models, and then port it over to mandatory law. So the truth is that the Trump administration, I think, is thrilled they have the Innovation Center, is thrilled that it was funded by somebody else, and is thrilled that they now have the regulatory power to test new models and then make them regulatory requirements. And so I think that in the US, we're going to see a lot faster movement to coordinated care models, accountable care models, and other models of healthcare.
Actually, you mentioned about the reforms in the payment models, which are basically shifting the risk from the shoulders of the purchaser or the payer to the healthcare providers.
Right.
So they will be accountable for reduction of the cost. What will be the implications on the health outcomes?
It's a great question. And so if you remember the teachings of Henry Mintzberg, he would say, I think, and I probably shouldn't even try to quote him, but he would say governments are designed to control and to protect and to provide access. And providers are designed to provide care and provide cure. And suppliers and insurance companies are people in the middle of all that have profit margins. And so if you say, you take these three components and you try to create alternative payment models, how would you do that and protect quality and safety? And I think the reality is governments want a predictable budget. They want a predictable budget. We don't have it in the US because we have this fee-for-service payment environment and they can't predict and they can't control it going to 17, 18% of the GDP. Governments here, I'm sure, want a predictable line item for healthcare costs. And I think what that means is they will shift the provider delivery risk to the providers. And so they're trying to think of models that actually put providers in control of the risk and also maybe give them, in the US, maybe not so much here, some upside if they perform well. I think it's a fallacy to say that higher quality healthcare costs more. Actually, our work in this area would indicate that higher quality care means fewer days in the hospital, means fewer tests, means fewer antibiotics, means less variation, means more primary care, means more social determinants of health, means more genomic testing so you know which drugs work and don't work, so you don't spend a bunch of money on drugs that don't work. And so all of our data would indicate that high quality care can be a lot more efficient. And so I don't actually think the alternative payment models necessarily will have a negative impact on outcomes or quality. I think they could have a positive impact.
But under the condition that actually, in my opinion, if you design the control mechanisms properly and make sure that the quality indicators are also taken into account while assessing the performance and the payment, and where pay-for-performance systems are also getting quite popular in that sense.
Yes. And I think it's an evolution. I don't think you move from a fee-for-service model to a global payment model. I think there are steps in between. So in the US, they have something called value-based purchasing, value-based payment, which is a fee-for-service payment, and then you have a bonus or a penalty based on your quality metrics. And then they're moving from there to something called bundled payment, where for an orthopedic procedure, you put the hospital, the doctor, the implant, the post-acute care together in a bundle and pay for that bundle. And then they have an even more evolved model that's called an accountable care organization, where a health system, which includes hospitals, doctors, nursing homes, ancillary capabilities, signs up for a population and to take care of that population for a certain amount of money. And so what's happening in the US is the healthcare systems are evolving themselves, experimenting, learning, building the infrastructure for these models, so that as that risk gets shifted to them, they will have learned how to do it, and they will have the data, technology, and infrastructure that they need. One of the problems in the US is there are 900 different measures of quality and safety. And so you have Medicare measures, you have 50 states who have their own measures, you have commercial insurance companies who have their own measures, you have employers that have their own measures. And so it's really hard, and it's what Premier tries to do, really hard to standardize and normalize the performance across the whole country.
And you already mentioned that to be able to have this kind of reforms or drastic change in the healthcare environment, we need an investment for the infrastructure.
Yeah.
We need to measure the performance, which requires the technological investments as well, and training of the staff. And so far, if you look at the expenses for the US healthcare system, 25% of the expenses are already administrative costs.
Right.
And these numbers are around 10 to 15% for Canada.
Yeah.
So what will be the implications of these infrastructure investments and educational investments on the healthcare costs?
Yeah, you all do a much better job on the administrative costs than we do, and I think it's because you have more standardized measurement even across the country that the government influences. I think we'll have more of that in the U.S. Over time. I think one of the advantages in the U.S., in my opinion, is the consumer and the disruptors in the U.S., like Google, like Amazon, like these companies that are using artificial intelligence and data to try to predict needs of patients. And I think that they can disrupt the market in the US maybe easier than they can disrupt a healthcare market like Canada, because they can't get in as easily as they can get in the US. And I think that disruption, which is going to be very patient-centered, because all of those companies live and breathe consumer. What does the consumer want? How do I make it more convenient? How do I make it more effective? And in the US, when they get frustrated, a disruptor gives them something to use as a catalyst to change the system. And so I think that this infrastructure thing, in many ways, is going to be driven by technology companies, data companies, with infrastructure that actually does a better job of helping a health system figure out how to take that risk. And I don't think, we can all be critical of our healthcare systems. I don't think 10 years ago we would have been in a place where we could do that, and I don't think you would either. We had 20% adoption of EHRs, electronic health records, 10 years ago. We have 80-90% adoption now. If you don't have an electronic health record, it's really hard if you don't have that infrastructure to coordinate the healthcare. So I think I think I'm the luckiest girl alive, because we're in a place and a time with artificial intelligence, with cloud-based computing, with technology infrastructure, with empowered consumers. And we just have to figure out how to get the governments and the insurance companies to allow the evolution to happen. But I think that infrastructure thing is a totally different dynamic today than it would have been 10 years ago.
Now, having understood that the current challenge of the healthcare system and urgency of this transformation, I would like to ask your vision about the future healthcare system. So how do you paint the picture of the future healthcare system? How will be the healthcare system in 10 years now?
It's a great question. And so unfortunately, I have to bring my uniquely American opinion to it, which is that the best system in my mind is going to be a hybrid system. And I said when I was at McGill, I wrote my papers around what I was learning and what the strategy for Premier would be. And the aha moment to me at McGill was this concept that you could have a very important social mission, but that you could figure out how to execute that social mission with business principles. And so to me, the best possible outcome is that you have access to care for all. So everybody has access, either through Medicare, Medicaid, commercial insurance, insurance exchanges, but you have access to health care for everybody. That you have minimum benefit plan design, so you know you have at least the right health care benefit plan design. I think your layering is challenging because you're missing some of the big pieces that might make it unaffordable, the layer 2, layer 3 healthcare coverage. And then I think that you take those federal or state dollars in global payment models and you force the delivery system to a risk-based model where they have to figure out how to most efficiently and clinically effectively deliver the care within the level of investment a country decides they're going to make in healthcare. And I think nobody has, or at least we haven't decided how much investment we're willing to make to the detriment of education or other programs, infrastructure, roads, other programs in the country. So you define the investment level, you create these global models, you then send it to the private sector, in my mind, that enables competition amongst and between different parts of the system because it keeps us all on our toes. I mean, Premier does $60 billion of supply chain buying, and who do you think I worry about every night? We buy drugs, we buy supplies, we buy commodities for hospitals, for doctors, for nursing homes, for all kinds of people. Amazon, right? Amazon's a huge disruptor. Amazon sees that $3 trillion of spend in the healthcare industry. And I think it's a good thing that it keeps me awake at night because it makes me keep thinking about who's going to disrupt, who's going to create an Uber, who's going to create a product or a service that is more efficient, more effective, patients and consumers like it better, and it delivers better outcomes. So I believe that these hybrid models where you take those fixed budgets and you enable parts of the system and competitors to keep each other honest, and you foster innovation, and you foster new models, and you foster experimentation. But it's messy, it's not easy.
So basically, you believe that the main drivers of this transformation will be the purchaser and the competition, market competition for the US system?
There's an interesting thing. So it has always been, actually, the way it has worked in the US really has been the purchaser being Medicare and Medicaid, setting policy, setting models, setting payment levels, and then the commercial insurance companies follow. So you have sort of in the US that force, and then now we have this consumer product development force of new technologies, Amazon, Google, AI, cloud, all that stuff. And we're trying to figure out how to put those pieces together. What's interesting in the US now is that employers, large employers who pay about 30% of the healthcare bill, are increasingly frustrated with insurance companies. And they are starting to go directly to providers. And I think it's this concept of people figuring out if you really want to change the way healthcare is delivered, you actually have to do it from the inside of the healthcare system. And so they're going directly to providers and asking providers to take risk. And they're threatening to take a piece of the money away from the insurance company to give it to providers to actually change the way that they're delivering care. So there's all kinds of dynamics with federal programs, state programs, employer programs, and unfortunately, there are not standards of technology interoperability, there are not standards of quality and safety measures, which are the things that I think the federal government could require. And that would make the evolution much faster.
So if we shift our focus to the Canadian healthcare system, and at this point, I would like to make a quick clarification about the Canadian healthcare system as well to avoid any misperceptions. Since we have a universal healthcare system, most people believe that we have a public healthcare system, but in Canada we have a public-private hybrid healthcare system as well. So in terms of delivering of the healthcare, the private sector is delivering the healthcare. The physicians and most of the hospitals are private entities. However, the government exercises certain authority on these healthcare providers while they are delivering their healthcare. In the meantime, regarding the financing of the healthcare, it's not fully publicly financed, publicly funded. 70% of the healthcare is financed by the public through the Medicare insurance programs of the provinces, where 30% is funded by the private sector. But thinking about this hybrid model, which is very specific to the Canadian healthcare system, because once we look at the other examples, other countries which have universal healthcare system, Canada could be the only one which the private sector delivers the healthcare. What will be the challenge? What will be the basic steps that we have to go through?
Well, I think one of the challenges you have is the same as we have, and I think your provinces and territories are like our states. And so we have 50 different programs, and you have 13 different programs. So I think one of the big challenges is, it's really interesting because I do think if you put 50 people in a room together, you should be able to come up with a standard of measurement for a healthcare system. One standard of multiple measures, but one standard. So it was so interesting when we built this collaborative around moving mortality, readmissions, and all those things I described, cost all at the same time. Nobody was measuring harm. Nobody knew how to measure harm. There were not standard measures of harm at that time. So we decided to get 50 physicians in a room. And we wanted to develop 20 or 30 measures of harm. We were going to build them in our technology, and we were going to measure them. So how long do you think it took us to get to 25 measures of harm? And this was just for 400 hospitals. This was not even for a country, but 1 year. 1 year. We did the measurement, and we were measuring 25 or 30 forms of harm. And then we created this index called a harm index so that you could compare health systems, and it had things like sepsis and CAUTI and CLABSI and all kinds of things. So how many of those 25 measures do you think actually moved the harm index for a health system? 4. Should have known you would know. 4. And so there's this concept of we should all be able to get to standard measurement. It's fewer measures than we think. And we have the technology, we have the technological ability. So this is all about people, culture, turf, politics, money. It's about all those other things. It's not about the ability to actually define what a high-performing healthcare system looks like. we built this collaborative where we were measuring all these things. We got 400 hospitals to agree to a common definition of observed to expected mortality, common definition of harm, common definition of cost, like what are the elements you're going to include in cost, common definition of patient satisfaction, common definition of readmissions, common definition of the evidence-based care, checklist of things that we were going to measure. And we identified the top 20% high-performing health systems as the bar. And we ran that collaborative with those 350, 400 hospitals for 6 years, saved $18 billion just with 400 hospitals, and reduced observed to expected mortality by 200,000 lives. And so it's not that this is not doable. The question is, how do you create the will and how do you create the environment for people to collaborate and people to improve?
So as I mentioned before, since although the healthcare is delivered by the private sector, the governments, either the federal or the provincial government, exercise a certain authority in the Canadian system compared to the US.
Right.
So is it a good thing for us or the bad thing, do you think?
I think it's such an advantage for you. So I think if the federal government defined standards of technological interoperability, if they defined standards of quality and safety and cost measurement, if they had a block granting process that was fair and equitable and adjusted for socioeconomic factors for different markets and that sort of thing, and then if they said to the healthcare system, you go figure it out, all of the first part works. It's that last part that's really hard, right? And I think that because you don't have, in the US health systems, no longer are hospitals separate from doctors, separate from nursing homes, separate from, they're very integrated and they're getting bigger and bigger so that they could actually take in that risk and then within a system of care, coordinate the care, integrate the care, have the infrastructure, and be able to afford to have the infrastructure. I think if we continue to keep the delivery of care as a completely fragmented cottage, separate and independent pieces and parts, it's really hard to drive the coordination that you need to drive to get to the different outcomes.
So the healthcare industry is also already a very complicated industry, very complicated environment, and basically the main reason for that is there are many stakeholders who are contributing to the healthcare value chain, including the patients, healthcare providers, physicians or other healthcare providers, policymakers, insurers, and so on. And most of the time, all the time, they have their own priorities and objectives, and most of the time they are conflicting to each other. And with this new picture of the healthcare system, you are emphasizing the role of integration through the continuum of care, which is focusing on the integration of all these different components, all these different stakeholders, and it's asking to work together, which is already very challenging. So how can we handle this challenge through this transformation?
Yeah, it's really hard, and I think one of the things we've learned through all the collaboratives that we've done with the 4,000 and the national footprint is, one, it's not that we lack data because there's more data and people don't even know what to do with all the data they have. So the question is always, how do you figure out what the biggest root causes of the problem are, and then how do you focus on that? And if you're going to focus on a root cause, how do you figure out the accountability of the payer, the provider, and the patient in that? So for example, one of the things that we learned in orthopedic bundles was that the biggest cost factor wasn't actually what happened in the hospital. The biggest cost factor was the long-term care that happened after, the skilled nursing care that happened after. And we said, okay, it costs a lot. Patients don't like it. They don't want that. They want to be recovered and back to their everyday living as quickly as possible. And so we went to work in the bundles on post-acute care. We went to work in harm on sepsis, because sepsis was the number one challenge with preventable mortality, and after 3 years it was number 14. And so I think that the way, I don't think we can wait for some magic, integrated, accountable system. I think we have to be figuring out what are the most significant focus things that we could do within a model. And in that case of the bundled payment for orthopedics, the skilled nursing facilities were not aligned with, in many cases, the healthcare system. And the orthopedic surgeon was most likely an independent specialist. So what happened was, once you, with the data, identified the problem, the specialist said, oh, I didn't even know. I didn't even know that they were being sent to skilled nursing for 100 days. The patient said, no, I don't like that. I never wanted that, but somebody told me to do that, so I went to do that. The health system said, well, I'm going to save money in the bundle if I don't do as much of that, so that's good. The only one who suffered was the skilled nursing provider, who had less patients now. And what happened was the healthcare system, the physician, and the patient just started to change the practice patterns. And so I think to the extent we can figure out what those big root cause problems are, and we can figure out how we meet the needs of 3 out of the 5 participants or 4 out of the 5 participants, you can start to affect change.
Actually, in other words, this transformation does not only include changing the payment models, this transformation requires a big cultural change in the healthcare environment as well.
Yeah. But the healthcare environment, I don't know, my sense is when you put the data in front of physicians or in front of hospitals or in front of other practitioners, public health, they want to get to better outcomes. They just either don't know how, or they don't know how to work through the barriers, or they don't have the data. And so actually in our world, we created these collaboratives, and there was no government mandate to do it. There was no payment associated with it at the time that we did it. And we said, who will sign up to, 1, be transparent with each other, all 400 of you, 2, agree to standard measurement, 3, participate to drive the performance improvement, 4, use standard technology to do it so you have standard measurement. And they all did that because they wanted, and maybe this is the market competitive environment in the US, they wanted to be able to say, I have the best mortality scores, the best harm record, the best quality, the best evidence-based care, the lowest rate of readmissions. And if you come to my healthcare system, I'm not going to kill you, I'm not going to hurt you, I'm not going to give you non-evidence-based care, I'm going to try to satisfy you as a consumer. And so the progressive thinker said, it doesn't matter what the government does or what the insurance companies do, that's what I want to be. But it was 400 out of 4,000. So the real challenge for all of us is how you scale that improvement.
And to close the loop, I would like to get your opinion regarding measuring the success of this transformation. So you already mentioned that in the current healthcare system, and we also experience this in the Canadian context, we struggle in measuring the performance, either the healthcare outcomes or in the process and efficiencies. We already struggle with the traditional healthcare system, and now with this redefinition of the healthcare and the transformation of the healthcare, we will focus more on the integration through the continuum of care, which includes many stakeholders with different priorities and the objectives. So how can we assess the performance or the success of this transformation?
So to me, you have to figure out what the accountabilities are. And I think in most countries, it's very confused. So what is the accountability of the federal government? And what would those measures be? So the federal government might be access to care, it might be percent of GDP, it might be total cost per capita, it might be life expectancy, it might be infant mortality. So figure out the accountability first and say, okay, that's what the federal government owns. What do insurance companies own? Insurance companies own catastrophic insurance coverage, risk underwriting, premium growth, administrative percentage. What accountability do providers own? Providers, hospitals, and doctors own clinical outcomes, length of stay, readmissions, quality, reliability, what those measures would be. And so I think if we could figure out and agree on who's accountable for what, and then what accountability does the patient have? Because I think one of the challenges with all of our healthcare systems is the patients are not accountable for any part of this. And so how do we embed patient accountability? In the US, they've started these things called high deductible health plans. I don't know if you have them here, or HSAs, where actually the employees, and we have about 80%, 85% of the premier employees have chosen this. They pay their own healthcare bills. So we basically set the money aside, and then they use the money, but they get to keep it if they don't use it. And there's a problem with it, and there's an advantage to it. A couple of advantages are it gives consumers visibility to what healthcare really costs and what it really looks like. And they have very little visibility to that otherwise. Two, it has led to 30% reduction in their use of healthcare. The natural downside is, are we all going to pay later because they're not getting or not doing the things they need to be doing now, and they're deferring it because they're young and invincible and they don't think they need anything. But I think, these models of figuring out the accountability, figuring out the small subset of measures, and you all have the ability to standardize that across the country. I mean, we have the ability to do it for Medicare. We don't have the ability to do it for Medicaid because every state does it their own way. We can't force the commercial insurance companies or the employers to do that at this point. So I actually think you should lead the way. You should lead the way for the world in standard measurement and accountability for the various buckets of healthcare.
Okay, and I would like to stop here and open the floor for some questions from the audience. Please.
Yes.
We will have a microphone.
Yes. Okay. Okay. I would like to have your opinion about the mode of payment to the doctors. Right now in Quebec here, we pay the doctor according to the number of procedures they perform.
Right.
But the new government that we have just elected a month ago wants to change that for a payment, a capitation model, which means doctor will be paid according to the number of patients that they have on their caseload.
Right.
Did you study the difference between these two modes of payment, and in your opinion, what would be the more efficient way to pay doctors, let's say?
Yeah, it's a great question. So the question is, how do you pay doctors, and how do you move from fee-for-service, which is a volume-based system, to a capitated or other system? And we have very much a fee-for-service system today. It does drive in the U.S. overutilization, certainly. And so this movement to some form of alternative payment model. The risk of capitation is, again, do you get stinting on care, and you get challenges because the capitation rate isn't appropriately set. But everybody in the U.S. that's in a regulatory role wants to move physicians into the position of control. and give them the capitation or the bundle and let them navigate the system. The problem with that there and here is one, many of the physician groups are not of size and scale. Most of them don't have a lot of infrastructure. Most of them don't have a lot of money. And the ability for them to assume that risk and build that infrastructure and then manage that risk is very challenging. And the burnout, the physician burnout that already exists because of the craziness of the system would potentially get worse. And so I actually, a lot of people say hospitals shouldn't employ physicians, systems should be all independent. I actually think if you can create clinically integrated networks, bigger infrastructure, bigger organizations that can take the capitated payment and then figure out their distribution models, that works better. But I think that in the US, it's playing out always. What's strange in the US, because it's a capitalistic market, is the private equity firms are now buying physician organizations, big physician organizations. They're going to help them build the infrastructure. And they're going to help them then commoditize the rest of the system and navigate the system. But what do all PEs want to do? They want to sell, right, eventually, 5 or 6 years. So then who are they going to sell them to? So a lot of challenges, and it's very much in flux in the US in terms of the physician models.
Thank you very much for sharing your insights and experiences. My question is regarding the data. You mentioned that you have access to 45 million. You have access to data for 45 million patients just in US. So I believe there is ample data available when it comes to healthcare industry. On the other side, we see that there are so many healthcare startups which are trying to enter into healthcare industry. Right. Like we know in Montreal, there are so many startups. Right. But and also we know that healthcare industry is it's not one of the top industries when it comes to technology adoption, right, as compared to like banking industry or like right, technology industry itself. Right. Right. So if we have the data, so what do you think are the real challenges when it comes to technology adoption? Like.
Yeah. So we, as I said, have 45% of all the patients in the country, so it's a lot more than 45 million. So this is not about a shortage of data, to your point. Lots of the startups, and everybody has pieces of the data, and nobody has all of the data. All of the data would be all of the payer data, which is very horizontal, and all of the deep provider data now that we have EHRs, in every place, and the connection of those two things. And so people are spending a ton of money on technology and on data analytics, and then they get all that data. And if you're a chief medical officer or you're somebody, you then have to take all that data and try to get physicians one at a time to change what they're doing. And that's where I think the big problem is. I don't even think we have hit the big problem yet. We all think the problem is all these data and technology to gather data. The big problem is, how do you take that data, figure out what the focused work is to move the needle, as opposed to boiling the ocean, and then how do you get it into the workflow? Because if you cannot get the clinical content, and I noticed you guys have Choosing Wisely Canada. We have Choosing Wisely US, which is the clinical protocols. We just bought a company last week. It's the first one I found. I've been looking for years. That has all the Choosing Wisely guidelines embedded. They have built the interfaces to Epic, Cerner, and most of the EHR systems. And we're going to take that data on 45% and put it in there as well. And then we're going to alert the physician. You're getting ready to order something that's not a generic. You're getting ready to do a procedure that's outside of protocol. You're getting ready to use a high-cost porcelain implant, on a 95-year-old patient. And in the workflow, the physician then gets to choose I accept your new recommendation or I ignore it. So you don't take away the autonomy of a physician, but you have all that information. And over time, you can learn how to alert only the important things. And when you see 98% of physicians ignore that one, and you see that 98% do this one every time, and then you actually quit alerting them because they change their practice patterns. So to me, the big challenge is how do you get it into the workflow? Because I just don't know how you change physician behavior one at a time unless you get it in the workflow. And even then, it's going to be very difficult.
Well, speaking of physicians and workflows, part of redefining or redesigning healthcare will be the change in jobs that will happen as a result of, you mentioned infrastructure, new technologies. Yeah. So how do you see the redesign of jobs of specialties like, for example, radiologists, where AI is already, I mean, the current technology is taking a huge proportion of the tasks that they are doing, from image recognition, analysis, diagnosis, reporting, etc. And the Canadian Association of Radiologists here has already voiced its concern. So how do you see this change happening?
You know, I think there is a lot of strength in those groups. Part of the reason in the U.S. we haven't been able to get people to practice at the top of their license and let other people do other things is the territorial nature of the different groups. So what pharmacists can do and what nurses can do and what PAs can do and what doctors need to be doing and what radiologists need to be doing and what telehealth can do and what AI can do. I mean, I think if we could all step back and suspend our livelihood, right, which is really hard to do, and say in a healthcare system, if we don't have enough primary care physicians, but we can use telemedicine, or we need to shift the balance of supply and demand of different roles, and they're different depending on the specialty and depending on the technological capabilities and depending on the patient level of interaction. I just think we have to be open to it, and I think the people who embrace it and create a new model, like often I think these new models come from really innovative people within the current segment. And you know, I say to our healthcare systems all the time that this is like a treadmill, and the treadmill's starting to go faster. And if you're standing still on the treadmill is going to throw you off. But if you're running as fast or faster than the treadmill, well, if you're faster, you'll run into the front of it. But if you're running as fast as the treadmill, you will figure out a way. I mean, we're all ingenious people, so. I just think it's will. I think it's will. I don't think it's clinical quality. I don't think it's clinical quality. Because I think you can combine a person with technology, with data, and have better clinical quality.
One of the things that you haven't mentioned very much is the pharmaceutical industry.
Oh, gosh.
And the pharmaceutical industry is one of the biggest drivers of healthcare costs at the moment.
It is.
And it's an industry which is a for-profit industry.
Yep.
And they have a huge vested interest in obviously their product and utilizing it as much as possible.
Right.
And they are very, very influential, both politically and not. And I'm not certain what the percentage of pharmaceuticals contribute to the U.S. healthcare system, but I should imagine it is a substantial amount.
A lot. Yeah.
And it's very unregulated at the moment.
Yes. So, boy, so many thoughts, and I'm just going to throw them out at you so you can think about all these thoughts at the same time. The first thought is that most of your pension plans have huge investments in pharma companies. So to the extent that we change that model a lot, we all need to think about the economic impact of it. That's the first thing I'd say. Second thing I'd say is I don't buy for a minute that they won't innovate and do research if they don't get the kind of profit margins they have today. Lots of other industries innovate and do research with profit margins that are different than the ones they have today. Third, I would say that everybody in the US believes that we subsidize the rest of the world because our pharma costs are 30 to 50% higher at a unit price level than other countries in the world. So one of the scariest things, and I was saying this, I'm in a meeting 45 minutes north of here. I was saying in that meeting where there are people from all over the world that the US government and the regulators have the power, this is not legislative. They are creating something called an international index. And they're taking the OECD countries and they're comparing unit pricing for Novartis and all these other pharma companies of the same product in all those countries. And they're going to create something called an average international index. And they're going to tell the pharma companies in the US that's what Medicare's paying plus an administration fee for the doctor. And so the pharma companies are going to have to decide if they're going to take a 30 to 50% cut. Because if it's not reimbursed at that level, the healthcare systems won't pay for it at that level. Or they're going to have to decide that they're going to go back to all those other OECD countries and raise your pricing so that then the average index doesn't go down by 30 to 50%. So there are so many dynamics right now happening where the U.S. is trying to figure out, and then, but none of that solves the real problem, which is the length of the patent life, and all of the games that pharma companies can play with, extending the lives of patents, or slowing down the adoption of biosimilars, or slowing down the adoption of even generics, or creating shortages. And so I think the US government has a drug blueprint, and it is multifaceted, that's going to move towards transparency. It's going to get rid of back-end rebates that people can't really see what the net cost of the drug is. It's going to have this international index component. They're going to force drug companies to print the price on the television ad. You know, the US is unlike a lot of countries where every day we all see the advertisements for drugs that could improve our lives. They're spending a lot of money on the opioid epidemic. The FDA commissioner in the US is one of the best ones we've ever had. And so he's starting to really make some changes. But having said all that, it's depending on who you are, commercial insurance companies would say it's 30% of their spend. Overall government there in US would probably say it's 17, 18% of their spend. It's growing at double, kind of the rates of inflation. And so I think it will be a big push. But we shouldn't forget the counterbalancing effect, because I think what's really going to happen is potentially pharma company stock prices will go down as this pressure intensifies. And so will the value of a lot of pension plans.
Oh, good. So thank you for a very interesting presentation.
Thank you.
I'm a family doctor, actually, and I've been involved in medical administration here for many years. And I've come to the conclusion that a large part of our healthcare problem here is that it's run by politicians who make political decisions, which often are totally illogical from either a scientific or medical point of view. Right. And I look at other countries. One of the first slides we saw had a range of measures. No one seems to be able to figure it out very well. I mean, nobody ranked terribly highly in all the dimensions. And I'm kind of puzzled by that. I think one gentleman here mentioned the ways of paying doctors and things. Nobody really has come to the conclusion that there's a best way to pay doctors. Different things have been tried, even in Quebec. For general practitioners, we've tried salary, we've tried hourly, we've tried capitation, we've tried by act, and the results have not been majorly different, in fact. So my question is, an extremely complex system like the US has, and I think we're simpler. We have access to enormous, almost total population data here in Quebec.
Right.
We could make a lot of good decisions, but we can't seem to coordinate our system to the benefit of patients. I mean, patients, particularly in a primary care system, get shuttled around. It's very hard to get things coordinated.
Right.
The simplest procedure, like getting 2 x-rays done at the same time, often can't happen. And I can't really understand why that is.
Why it's so hard. Well, I do think, one, it's because of politicians turning over 2 years, 4 years, 6 years, right? And so that you lose the continuity. And the other part of it is that money that comes, out of one pocket, might go into another pocket. And so we're redistributing the money as opposed to overall dealing with the lower cost of care. I think you're in a unique position. I was reading a paper on the way up here about you all thinking about a funded innovation center at a national level. And I think and this is why I'm encouraged in the US, because it's now a regulatory thing, not a political or legislative thing. And I'm actually very impressed with the level of competency and knowledge base for many of the folks who are in the Department of Health and Human Services. They have the data, they have knowledge, but they're not limited by the whims of the politics. It's why I think actually Obama establishing the Innovation Center as the test bed for new models at a national level and building in regulatory authority to implement them. And then, so whether it's a Democrat or whether it's a Republican, they both have this vehicle to regulate the models. And I think you all, if you had a centralized way of experimenting and defining measures and figuring out what worked and what didn't work, because all the work we do in our collaboratives, we always learn a lot about what works, and we always learn a lot about what doesn't work, or don't waste your time on that part. Like the harm measures, only 4 moved the mark, so the other 25 didn't really change anything, didn't happen often enough to change anything. I think you have an opportunity here to do that. And I don't know anything about the political system here much, but I do think there are ways to do it, and I do think that concept of a funded innovation center at a country level with regulatory authority to take what works and try to implement it broadly at scale is an interesting proposition. I think that actually keeps some of the innovation in the system too, because I think the challenge with purely federal or state regulated programs or insurance or payment systems is it's hard to get innovation into those organizations.
So I had a question about politics and healthcare. So there seems to be a movement in the US for Medicare for all. Yeah. How do you think that will impact the delivery of healthcare in the US?
Never happen.
It'll never happen.
I don't think so. I think that what could happen is people choosing to buy into Medicare. But I think that it is, there is such bipolar behavior, partisan behavior, that I think a concept that dramatic would have a hard time actually happening in the near term. Now, maybe long term we'll all get to that place, and I think it could happen in stages. But I think in the short term, hard to see that happening.
Very nice to see you, Susan.
Nice. Nice to see
I
you.
have a question that really was about what we were discussing a few years ago about primary care and community care. And I remember you saying it was not so developed, especially in
Right.
your organization. I was just wondering, how was it measured? Did it develop? How is it doing today, primary care and community care in your organization, which is half of the country?
Yeah, so most of the primary care physicians are aligned with health systems. So they're either employed or they're a part of integrated delivery systems somehow. Many are increasingly employed by insurance companies, which is an interesting dynamic as well. We have not at all cracked the code on community social care systems. I think we've made some progress with these alternative payment models who have found that churches and that social public health organizations can help manage the overall care delivery, but it's only when there are those alternative payment models in place. It was interesting, in the US, I would say we're still spending 1% of the total spend is on community care kinds of things. I was surprised to learn that in many other countries of the world, even that have combined social care and medical care, that it's only 2 or 3% or 4%. And that in the local government debate or the state government or the province debate, the healthcare costs get the biggest majority. So we have not made much progress. We have some systems who are the very progressive ones who want to take risk and therefore want to leverage. We have some really creative things happening where a healthcare system created what they called a special care center. And I think it had 2 doctors, 1 nurse, 1 social worker, and coaches. And they took their chronic patients and they basically, in a conference room with computers with those 10 people, focused only on all the needs of those chronic patients, which were transportation needs, which were food needs, which were socioeconomic needs, more than they were the needs of the COPD patient or the heart failure patient, and had tremendous results, tremendous lowering of cost, tremendous reduction in ER visits, tremendous reduction in admissions, a lot happier patients. We have some health systems who have created prescriptions for food. And so they bring food trucks into the healthcare system. The doctor prescribes food, healthy food, in a prescription, and they use that prescription to get the food. So there's a lot of million flowers blooming, individual initiatives around those concepts. They just haven't been scaled.
Thank you both for being here tonight.
Thank
Thank you. We haven't really heard a lot about the professionals who make the largest proportion of the healthcare workforce, which is nurses.
Yeah.
And they're at the front line and they feel the effects first of cuts, and they're also innovating at the front line. So
Right.
what do you see the role of nursing in redefining healthcare?
Yeah, it's a great question, and it's probably one of the most underappreciated roles, along with pharmacists, in the healthcare system. I think the ability to leverage nursing, particularly for chronic patients, and for cost-effective healthcare, caring patient experience, all those things. I think that this fight over top of the license work and who does what continues in the US. But I actually think with all the collaboratives that we run, so we run this collaborative around cost, quality, safety, harm, all that stuff. We run a collaborative around risk-bearing models, these things called accountable care organizations. We run a collaborative around bundled payment. And I would say in every single one of them, nurses drive all the results. Nurses drive all the results because they execute the change. they execute the change. You need leadership from the champions. You need leadership from the champions. You need an infrastructure of data technology, and you need a performance improvement methodology. Doesn't matter which one it is, you just need one. But it's the frontline nurses that actually change the behaviors and change the outcomes. And I think if we would all leverage them as well as pharmacists and other allied professionals a lot more, we could deal with the shortage problems, we could deal with some of the staffing issues that we have.
I would like to get one last question for the time of sake. I think here we can have one, yeah. Yes, please. Thank you.
Actually, really quick, maybe another question can be added to that. In terms of stakeholders to help you with a change, do you typically deal with all senior management, or are you able to go deep down into the hierarchy to help with the change? Because that's the main trick about transformation.
Yeah, I mean, I think the real question is, how do you create the grassroots movement? And so I think you have to have leadership from the top. You have to have the data technology. You have to have the milestones. I mean, we actually did what's called a realist evaluation. So we studied the best performing health systems and the worst performing health systems, and we tried to figure out what is it that made the difference, what is it that drove it. And the things we found were transparency of measurement, so the places that are posting on all the walls what the results are perform better. The ones that had champions and leaders, both C-suite administrative leaders, but more importantly, clinical leaders, clinical physicians who were champions of the change. The performance improvement methodology, the data and technology and standard measurement. And then this culture or will to change. And actually we found that short measurement cycles were really important. So people needed to feel the reward of having improved. So we had 350 or 400 hospitals doing this collaborative, trying to improve simultaneously all those measures. 6 years in, how many health systems do you think achieved top performing threshold in all 6 dimensions at the same time? 6. We had 6. So it just goes to show how hard, and of all those measurements, harm, quality, evidence, mortality, cost, readmissions, and patient experience, which domain do you think was the hardest to move? Cost? Patient experience. So in the US, top performing threshold was 73% of the patients would give you a 9 or a 10 on a scale of 1 to 10 of how satisfied they were. So how many of you in school 73 was a good grade? That was top performance. That was absolutely the hardest one to move, because that means the whole culture has to move and the staff satisfaction has to move. Because it's the least tangible, and it's the hardest because it's really, really, really cultural.
Okay, I would like to take this opportunity and on behalf of the Desautels Faculty of Management to remember this day. It's a small gift from us, and thank you very much for all of you for being here tonight, for joining us for this discussion, and thank you for your time. Thank you.
Thank you.